American Medical Association of Illinois. Along with me, I have Dr. Sudha Bopalam, who is the co-chair. So we are going to be the host for today's webinar, Thyroid Health and Disorders. And as part of the Health Awareness Committee, it's our pleasure to bring this important health topic to you. We appreciate all of you for being here today on a busy weekday. And we hope that you are staying safe and healthy and that you have received both the COVID vaccination and flu vaccination. And we want to thank the Schaumburg Township Public Library for providing us this platform to bring this educational webinar to the patrons of the library and to our other audience. And to give you this important topic for today, we have Dr. Pinky Kurani, who is a clinical endocrinologist. I'm going to give you a brief introduction on her. She has been in practice for 3 years now, and she's with Advocate Medical Group in Chicago. She has completed her medical school training at Drexel University, followed by internal medicine residency at Boston University and endocrinology fellowship at UC San Diego. Thank you and welcome, Dr. Kurani. We appreciate you taking this time amongst your busy schedule to bring us this important webinar. And I want to remind all of our audience that at the end of the webinar, we will have a Q&A session. And I request you to type in your question as they come to you in the chat box or in the Q&A link. And we will try to answer as many questions as possible at the end of the session. And I would like to again remind everyone that this is a health awareness program and for information session only. And if you or your loved ones are in need of any health care, so please contact your primary care provider or go to the nearest hospital. So I now welcome Dr. Pinky Kurani. Please go ahead and start your presentation.
All right. Good evening. Thank you so much, Dr. Dhananjaya, for that really kind introduction and for inviting me to do this talk today. It's a pleasure to be here and to discuss thyroid health and hypothyroidism. I'm hoping to really provide some practical information, review a lot of the common questions that I get regarding thyroid disease and thyroid disorders. Very commonly, I get questions regarding medication, natural medications, vitamins, just overall how to optimize thyroid health. So I'm really hoping to talk about those in a little bit of depth, but just initially get started with some, just information, background information on the thyroid, which will better help to understand how a lot of these medications and supplements may work. Okay, so getting started here. So the prevalence of thyroid disease, just really important to address. More than 12% of the US population will develop a thyroid condition sometime during their lifetime. Already, an estimated 20 million Americans have some form of thyroid disease. Women in general, more likely than men, are likely to have a thyroid condition, about 5 to 8 times more likely. The causes of some of the thyroid problems are largely unknown. Most of the thyroid diseases are lifelong conditions that can generally be managed medically. And lastly, an important group, pregnant women with undiagnosed underactive thyroid levels are at increased risk of miscarriage, preterm delivery, and most importantly, severe developmental problems in their children, which actually can be easily treated if found early on. So just going over first the basics of the endocrine system, which will help us understand the thyroid physiology a bit more. So the endocrine system is, as you can see here, it's a network of glands that produces and secretes hormones to regulate body processes. Hormones are chemicals that serve as messengers, and they control and coordinate activities throughout the body. Hormones control growth, reproduction, energy use and storage, and glucose levels, just to name a few of the processes. As you can see here, you have the hypothalamus and the pituitary, which are in the brain. In the neck, you have the pituitary and the thyroid and the parathyroid glands. And then in the abdomen, you have the adrenals and the pancreas. And then in the pelvis, you have the ovaries in the females and the testes in males. So what is the thyroid exactly? So as you can see in this image, it's a butterfly-shaped organ, about 2 inches long. as the normal size. It's located on the front lower area of the neck, and it rests right where a bow tie would rest. The two sides of the thyroid gland, as you can see here, lie on either side of the windpipe, which is right here in the back. And it's connected, both lobes of the thyroid gland are connected by this band called the isthmus. So the gland itself makes thyroid hormones, which are then released into the bloodstream and delivered to tissues in the body. Thyroid hormones, like some of the other hormone systems I mentioned, but thyroid hormones in particular control the body's metabolism, so how fast or slow it works, the body's temperature, weight gain, weight loss, and weight changes are largely controlled by the thyroid as well. The heart rate, how fast or slow your heart is beating, and breathing as well. And then lastly, the nervous system, which regulates a lot of the neuronal processes in the body as well. So what can go wrong with the thyroid? You can have an underactive thyroid, which is known as hypothyroidism. You can have an overactive thyroid, which is known as hyperthyroidism. There can be inflammation of the thyroid gland, which is known as thyroiditis. There can be abnormal enlargement of the thyroid gland, which is known as a goiter. Lumps can form on the thyroid gland, and those are called thyroid nodules. And lastly, there can be cancerous growths of the thyroid gland as well, so thyroid cancer. Important to know that thyroid cancer, most of the time, if it's the most common type, it's generally managed by endocrinologists and not oncologists, which is a little bit more reassuring in the sense that thyroid cancers are usually very treatable and have a good prognosis. Okay, so I think we missed a slide here. Okay, so thyroid hormones. So understanding how the hormones work is going to be extremely important in understanding how some of the medications may work and whatnot. So the hypothalamus, which sits in the brain, releases a hormone, and that hormone is sent to the pituitary gland. So both the hypothalamus and the pituitary gland together control that thyroid gland. And actually, the pituitary gland is what we call the master gland of the endocrine system, and it controls a lot of the other endocrine organs, and it gives signals to the other endocrine organs as to how to perform their actions. So TSH, which is released from the TRH, which is released from the hypothalamus, signals the pituitary gland to release TSH, which is known as thyroid stimulating hormone. Thyroid stimulating hormone then acts on the thyroid to produce two hormones. The thyroid gland, which is located in the neck, uses iodine from the food that you eat to make two main thyroid hormones. They're called T3, or triiodothyronine, and T4, which is thyroxine. So the thyroid gland, important to know, makes mostly T4 and only a small amount of T3. When the T4 actually reaches the tissue, the body itself converts it to T3, and that's how T3 is made. T3 is much stronger at the tissue level than T4. The thyroid also makes one more hormone. It's called calcitonin. It's a hormone that's involved in controlling calcium levels, but it's not a necessary hormone, and it can be elevated, as I'll mention later on, in some kind of abnormal conditions. So just a little bit more about understanding how thyroid hormones work. So as I mentioned, the thyroid gland makes mostly T4, so it makes about 93% T4, and then 7% T3 comes directly from the thyroid gland. The remainder of the T3 comes from the conversion of T4 to T3. And then T3 exerts most of its action on your tissues, so the heart, the nerves, the bones, the liver, the muscles, and the other glands of the endocrine system as well. As you can see here, then once there is enough T4 in the blood, it sends a signal back to the hypothalamus to stop stimulating the thyroid gland. And so you have this very kind of concise and precise loop that regulates itself as long as everything is going okay. So thyroid blood tests, which are the ones that we need to know about? So the main blood tests, if you have a thyroid condition, you'll likely have had these levels checked. So the TSH is the thyroid stimulating hormone, and this is the most important and the most sensitive test. It's usually the first test to change at all. So even if it's measured by itself, sometimes that's sufficient on its own. It measures how much thyroid hormones the thyroid gland is asked to make by the pituitary. A high level of TSH means that the thyroid itself is not making enough thyroid hormone, and that's called primary hypothyroidism. Low levels of the TSH indicate that the thyroid gland is actually making too much thyroid hormone, and that usually indicates hyperthyroidism. Very rarely, the there can be an abnormality with the hypothalamus or the pituitary, which prevents enough TSH being made. And that results in something called secondary hypothyroidism, which is much more rare. Usually, if somebody has an underactive or overactive thyroid, it's a problem with the thyroid rather than the pituitary. So T4. T4, as I mentioned, is the main hormone made by the thyroid gland. And there's two levels that we can check. You have the total T4 and the free T4. The total T4 is bound to proteins, and then it attaches to the free T4. The free T4 is actually what affects your body tissues, and that's the one that we most usually test. Now, T3 is not as good and not as helpful for us in all conditions. It's useful and helpful. It's helpful in diagnosing hyperthyroidism to determine the severity, and that's when you have an overactive thyroid, because it's the first one to go high in hyperthyroidism. But in hypothyroidism, it's the last test to become abnormal, and it's not very helpful and not very reliable either. So, when we do measure T3, it's the total T3, because the free T3 is usually unreliable. It fluctuates a lot, but certainly it can be used, and we do check the T3 in certain conditions. You may also have seen something called the reverse T3 on your blood work. This is an inactive form of T3, and we only really use it if someone's extremely sick and has really abnormal thyroid tests, and we just don't know what to make of it. It helps us determine what the cause of that abnormal thyroid test may be. Okay, so moving on to antibody tests. These are some other tests that your doctor may order. So going over just antibodies in general. So the immune system generally protects us by destroying invaders like bacteria and viruses by making antibodies. In many people who have an overactive or an underactive thyroid gland, the body actually produces antibodies which affect the thyroid, and this results in thyroid autoimmunity. So it's essentially the body's own immune system attacking the thyroid. So measuring that levels of thyroid antibodies can help us determine what the cause of the thyroid problem is. If one has elevated levels of thyroid peroxidase antibodies or thyroglobulin antibodies, this usually results in a diagnosis of Hashimoto's thyroiditis, which I'll go into in a few moments. But essentially, that's a cause of hypothyroidism. Hashimoto's is just the name of the gentleman who discovered it. And so the antibody levels are very useful for the diagnosis of hypothyroidism, but we generally don't follow them over time. The TSH and free T4 levels will tell us what we really need to know about the actual thyroid function. A different antibody called the stimulatory TSH receptor antibody, also called the thyroid stimulating immunoglobulin, or the TSI antibody. This is an antibody that can be elevated in somebody with hyperthyroidism. And if that's the case, they usually have a diagnosis of something called Graves' disease. Once again, the name of the person who discovered it. And actually, in this case, we do often follow antibody levels because the antibody levels going down are sometimes an indicator that the Graves' disease is resolving on its own. It also helps us to determine if somebody is pregnant and has Graves' disease. It actually helps us determine the risk that if the antibodies will be passed down to the baby. So the TSH receptor antibody is actually quite useful to measure, but just not the TPO and the TG antibody levels. So moving on, two other thyroid tests that you may see that we don't commonly measure. So there's the thyroglobulin level. Thyroglobulin is a protein that's made by healthy thyroid cells and thyroid cancer cells. In the most common type of thyroid cancer called papillary thyroid cancer, which has a very good prognosis, we usually treat papillary thyroid cancer by removing the entire thyroid gland. And once a year, usually, we check the thyroglobulin levels because they should be close to zero if the entire thyroid is out. But if they're going up, it tells us that, hey, there's some tissue growing back. So we usually only use it once someone's thyroid is removed to check for recurrence of the cancer. Calcitonin, as I mentioned earlier, that's a hormone that's made by the thyroid. It's involved in controlling calcium levels, but it doesn't have a direct involvement. In a different type of cancer that's a little bit more aggressive, that's called medullary thyroid cancer, this level can be high. And so usually when somebody's had surgery for medullary thyroid cancer, we do tend to trend the calcitonin levels, and that's usually the only time that we check it. Okay, so moving on. So I'll first start off with hyperthyroidism. So hyperthyroidism is overactivity of the thyroid gland, and it results in high levels of thyroid hormones. and just increased rates of the body processes. It's quite common. It's about 1.3% in the general population, but it goes up to 4 to 5% in older women. And the reason it's higher in older women is because as we age, a lot of people tend to form thyroid nodules, and especially women. And sometimes these nodules can become active and cause hyperthyroidism, which is why it's more common in older women. Also, autoimmune disorders tend to be more common in women. So Graves' disease tends to affect women more disproportionately, and that may see an increased prevalence over age. Hyperthyroidism, a lot of studies have showed, which I've cited here on the bottom, that it's more common in smokers. Symptoms of hyperthyroidism, I often describe to my patients as just being on a lot of caffeine. There's a lot of nervousness, anxiety, you can have a rapid heartbeat, tremors of the hand, excessive sweating, weight loss, difficulty sleeping. Now, some people have no symptoms at all. Some people have more symptoms. So it really depends on the level of how high the thyroid hormone is. And also some people tend to be more sensitive where others are less sensitive. So it kind of varies. Now, hyperthyroidism, what is it caused by? So there's several causes. Graves' disease, that's the autoimmune disorder. That's why we always check an antibody level, the thyroid stimulating immunoglobulin in somebody who has hyperthyroidism to see if it's from Graves' disease. There can also be overactive thyroid nodules. So the little lumps in the thyroid, I'll show images of that later, but if they become hot, they can make thyroid hormones. Thyroiditis is just inflammation of the thyroid gland, and that can lead to a lot of release of thyroid hormone and cause them to be high. This can be caused by viral infections. Sometimes we don't know what causes them, but it's just overall inflammation, and it usually presents as a lot of neck pain, difficulty swallowing, sometimes fevers and chills. Another cause is increased iodine consumption. So for those who are in certain medications like amiodarone that has a lot of iodine, or people who received iodinated contrast for a CT scan, for example, may develop a transient hyperthyroidism. If they have nodules, there can be some autonomous thyroid overactivity. So treatment of the hyperthyroidism is a bit complex, and it depends on the cause. First, usually we calm the thyroid down with medications, and the two medications that we have on the market are methimazole and propylthiouracil. Important to know that both of these have a black box warning because they can very rarely cause something called agranulocytosis, which just is a scary term for a very low white blood cell count, which can predispose somebody to severe infections. So these medications are really not something we like to use lifelong. It's definitely something we use to calm the thyroid down first, though, when the thyroid levels are really high. Once the thyroid level has calmed down, depending on the cause of the thyroid disorder, hyperthyroidism can actually resolve on its own. And if that's the case, we can monitor it. But if it doesn't, we generally recommend either radioactive iodine or having the thyroid surgically removed. Radioactive iodine is a pill or capsule that you take that actually has a little bit of, it has radioactive iodine, which destroys the thyroid gland and stops the tissue from working. I'll get into that a little bit later. And lastly, you can have this thyroid surgically removed. And that's as simple as it sounds. Just go in and remove part or the entire thyroid. So Graves' disease, just wanted to show some images. So Graves' disease, as I mentioned, is an autoimmune condition. So the plasma cells here in your body make antibodies. These antibodies then attack your thyroid, which is an overactive immune system. And then these leads to an enlarged thyroid, a lot of inflammation in the thyroid. And these damaged cells then leak thyroid hormone, which causes high levels of thyroid hormone in your blood. Graves' disease, you may also have seen, leads to the classic eye changes, which we call Graves' ophthalmopathy. There's a lot of pressure behind the eyes and inflammation of the tissue behind the eyes, which kind of pushes the eyes out. And so you get the bulging eyes, the eyelids retract, and there's often redness behind the eyes. The main indicator is here, the top of the eyelid you should never see white above the top of the eye. So when there's white above the top of the eye, we usually call that subproptosis or exophthalmos, which is just a medical term for this that can result caused by Graves' eye disease. Okay, now we're going to focus more on hypothyroidism. So hypothyroidism is much more common. Hypothyroidism is an underactive thyroid gland. It can manifest with fatigue, just feeling very tired, weight gain that can occur quickly or over a period of time, dry skin, takes the moisture out, just feeling itchy and dry sometimes, hair loss. The hair loss with hypothyroidism is usually diffuse, so it's all over. And then lastly, constipation. It's important to remember that these symptoms can happen even in the absence of a thyroid issue. But they are very common hypothyroid symptoms. So if you're having any of these symptoms, it's very reasonable to check a TSH level because it's easy and it's very treatable. Now, subclinical hypothyroidism is an earlier and milder form of hypothyroidism. Between 0.3 to 3.7% of the population in a lot of the studies have hypothyroidism. It occurs more frequently in women and those over the age of 65. And the diagnosis is very simple. It's made by a blood test. So in primary hypothyroidism, which basically just means it's the thyroid that's not functioning well, your TSH level is high and the T4 level is low. Subclinical is that pre-form of hypothyroidism where you have a high TSH, but your T4 is still normal. So the amount in the blood is still normal. And secondary hypothyroidism is very rare. That's when the pituitary or hypothalamus does not make enough TSH to stimulate the thyroid gland. And so in this case, you get a low TSH and a low T4. Luckily, hypothyroidism is completely treatable. Okay, so what are the causes of hypothyroidism again? So the most common cause is Hashimoto's thyroiditis. That's the autoimmune where you have the elevated thyroid peroxidase antibodies. It can be caused, of course, by surgical removal of the thyroid. If you've ever had radioactive iodine, which is different from radiation treatment for cancers, for example, can lead to some destruction of the thyroid tissue. Congenital hypothyroidism is hypothyroidism when diagnosed at birth. It's just the absence of a thyroid in babies sometimes. Thyroiditis can cause hypothyroidism and hyperthyroidism. So thyroiditis is inflammation of the thyroid due to an autoimmune attack or a virus. Certain medications like amiodarone, lithium, interferon alpha, which are some therapeutic agents that they're now using, interleukin-2 can also cause hypothyroidism. If your body's not getting enough iodine, which I'll go into in a few moments, or too little or too much iodine, that can cause hypothyroidism. If there's damage to the pituitary gland. And then lastly, just other rare disorders that can kind of deposit abnormal substances in the thyroid that stops it from working well. Okay, moving on to the next slide here. Oh, I'm sorry. Okay, so treatment of hypothyroidism. So the standard treatment and the treatment of choice is levothyroxine. Levothyroxine is T4. If you remember, I mentioned that the thyroid makes mostly T4, a little bit of T3, but your body will convert the T4 to the T3. So the treatment of choice is T4. As you can see here, the tablets, they come in several different doses. And it's called levothyroxine is the generic, Synthroid is the brand. Both the generic and the brand name are both equally efficacious, but they have different bioavailability, which basically means that the amount that's actually being absorbed into your body and affecting the tissues might be different between brands. So it's less important if you're generic or brand, but it's more important that you stick to the same one so that if you're switching between brands, you might be getting a different type of dose when you're switching. So sticking to the same brand is important. This medication is best absorbed if you're fasting, and it's best also taken on an empty stomach without iron or calcium, waiting 4 hours, because those can affect the absorption of this medication. Usually when we start a dose or change a dose, we recheck the levels in about 6 to 8 weeks. And then if it's normal, we check once every 6 to 12 months. Okay, so some people ask, so the treatment is levothyroxine, simple, it's T4, but what about T3? So there is a version of T3 on the market, it's called Cytomel, and it's a synthetic version of T3 that's available as a prescription. The thing is that even though most of the actions in the body are from the T3, it comes from T4. So you really only need the T4. Even if you are hypothyroid, the body will still convert the T4 that we give you to T3. Very, very rarely, someone may have enzyme defects that cause this conversion to be abnormal, but it's extremely rare, and we would see it in a blood test if we measured your T3 level. The other problem with giving Cytomel is T3 has a very short lifespan in the body, while T4 is much longer. So if we give you a dose of levothyroxine, it'll be steady throughout the day for a few days. But T3, it doesn't last too long. So taking one tablet every day, even multiple day dosing is usually recommended. It just doesn't lead to steady levels. So as I mentioned, after one takes Cytomel, the levels are high for a short period of time and then they quickly fall. So sometimes it has to be taken more than once a day, and that still does not guarantee that the levels will be smooth. High T3 levels, because as I mentioned, they work directly on the tissue, they can lead to rapid heartbeats, insomnia, anxiety, and may harm the heart and the bone. So I usually never start T3 alone in somebody who has cardiovascular disease or an arrhythmia or something called atrial fibrillation, because it can kind of exacerbate those conditions in general. So T3 can be used. It's not preferred though. And it should never be used alone to treat hypothyroidism. And unfortunately, a slow release version of T3 is not yet available, but if it becomes available, perhaps we would just need studies to see if that could potentially be a add-on treatment. Now, what about combined treatment with T4 and T3? So a lot of people who have hypothyroidism wonder, well, like a lot of people who have hypothyroidism, despite having a normal thyroid level, do not feel those symptoms go away. They still feel fatigue, still have the weight gain. So sometimes we do try to add on T3 to see if those symptoms can get a little better. So going back, so for the vast majority, combination therapy with T4 and T3 is not recommended, but a trial is reasonable and we do it in some cases. So as I mentioned earlier, it's not recommended in those with heart disease. It's not recommended in pregnant women because the ratios of the T3 and T4 are altered and that can affect the baby in different ways. And, thyroid hormone is very important for fetal growth. So we want to do everything we can to optimize those levels, especially in pregnancy. Older folks just have greater than the age of 65 have an increased risk of heart disease in general. So we try not to use combination therapy in older people. But it's, there's a point to be made. We don't know whether T4 alone mimics normal physiology. We're just doing what's based on studies and what we've shown to do. Thyrolar is a combination of T4 and T3 treatment that's available in the United States. Usually these combination products contain more T3 than the body naturally produces, and they can have similar effects to taking the T3 alone. And due to its once-a-day dosing, they lead to a rise and fall in T3 levels, which is a short period of time. There's some more interest in giving low amounts of T3 more than once throughout the day, which may improve treatment of hypothyroidism, especially if you don't feel well on levothyroxine alone. And there's been multiple randomized trials that we reviewed that show that combination therapy doesn't appear to be better than T4 therapy alone in controlling the hypothyroid symptoms. However, there are some people who do feel better on it. And in those cases, we do use it. So one option, which sometimes I recommend if these symptoms are persistent, is doing a trial of levothyroxine with Cytomel for 3 to 6 months. It's not routinely recommended, but we do sometimes do a trial to see if someone will feel better, if quality of life will be improved. And so usually candidates for this therapy include people who do not feel well on T4 alone, and especially if they've had that thyroid removed, they've had radioactive iodine treatment, or someone whose T3 levels are low. And with the reason I say it with thyroid gland removal and radioactive iodine is because there you have complete destruction of the thyroid gland. And so that 7% that your thyroid's making, it's gone in both of those. So it's reasonable to try. Okay, just missed this slide here. Okay, and then natural treatment. So we often get questions about natural treatments for hypothyroidism. So we do have natural treatments. They're called Armathyroid and Nature Throid. These are desiccated, which means they're dried and powdered forms of thyroid that usually come from pigs. They're made from animal thyroid and they're not purified. So the issue with these medications is that they contain other hormones and proteins that exist in the body outside of the thyroid. They contain both T4 and T3, but we do know that the balance of T4 and T3 is different in animals than it is in humans. And then also because we're now talking about these aren't synthetic, these are coming from animals, the amount of T4 and T3 can vary in every batch. So sometimes it can be difficult to get consistent levels. And it is important to note they're not completely natural because they do contain chemicals called binders that hold the pill together. So not entirely natural. And there's no evidence that it has an advantage over the recommended levothyroxine or Synthroid. But I have used it in some patients, and there are some patients who have symptoms of hypothyroidism when taking levothyroxine, and then they switch to some of these natural treatments and they feel better. And if I do that, I usually just keep a very close eye on the thyroid labs, mainly the TSH, because the T4 and T3 can be a bit altered when taking this medication. And it's reasonable to try in someone who just does not feel well on levothyroxine alone. Okay, now subclinical hypothyroidism, I just wanted to touch on because it's very common. 2% of pregnant women, between 7.5 to 8% of women, and 4.4% of men have subclinical hypothyroidism. So this is when the TSH is slightly high, but the T4 is normal. There are some studies that show that it may be increased with a risk of heart disease, particularly if the TSH is more than 10. But real solid data to establish if treating this helps the heart is actually quite limited. Overtreatment is also a concern, especially as we age. If we have too high of a thyroid hormone, it can kind of increase the effects, possibility of causing arrhythmias or kind of cause more stress on the heart than it should. So should we treat high subclinical hypothyroidism? Should we not treat? I'll get into that now. So this is a table that shows whether or not it should be treated. So if the TSH is more than 10, we should just treat, because there's definitely data for that it does increase cardiovascular risk. If it's between 7 to 9.9, if someone's young, we recommend treating, just because we don't know long-term, can affect the lipid profile, cardiovascular risk factors, quality of life, etc. If someone's over the age of 65, we tend not to treat, just because it can increase that cardiovascular risk. But if there are symptoms of hypothyroidism, like the weight gain, the constipation, the dry skin, the fatigue, we can do a trial for sure to see if it helps. Now, what if it's just slightly elevated? It's a little bit higher than normal, and normal is usually around 4, and it's from between 4 to 6.9. Depends again on the age. If someone's over the age of 65, we usually recommend not treating at all. There is some age-related increase in TSH, which is actually considered normal, believe it or not. So even though the upper limit of normal on the lab work is still the same as someone who's younger, we actually have more, the TSH can be a little higher when someone's older, and that's okay. So once again, if someone's less than the age of 65 and it's from 4 to 6.9, if there's symptoms, we treat. And certainly if it helps, we go ahead and treat that. The other thing to mention here is if somebody has a positive thyroid peroxidase antibody, then we do tend to treat more often than not, just because we know that there may eventually develop hypothyroidism because of the elevated antibody level. Okay, now getting into goiter. So what is a goiter? As you can see here, you have the normal thyroid, which is nice and small, and usually it's small that you shouldn't even be able to feel the thyroid. With an enlarged thyroid, just is the word for goiter, and that sometimes can present as bulging of the neck, just some enlargement of the neck as you see up here. It's common in about 5% of the people in the United States. Some people don't even know they have a goiter until it's palpated on a physical exam. The thing about a goiter is it usually grows outwards and not inwards, and so even if it's quite large, it usually does not push on the windpipe. Sometimes it can, and it can cause some difficulty breathing, especially when laying down. It can sometimes cause wheezing or a cough, even sleep apnea or hoarseness. The esophagus is more so in the back, so it's less likely to cause difficulty swallowing, though certainly it can happen with a really large goiter. Okay, so what is the most common cause of goiter in the world is iodine deficiency. In the United States, though, iodine deficiency is generally not an issue. We have iodized salt. Most of our food is fortified with iodine. So goiter is more usually caused by those who have a genetic predisposition to having the multiple nodules. Autoimmune thyroid diseases, both Hashimoto's and Graves', can cause the thyroid to be large. And thyroiditis, or inflammation of the thyroid, can also cause enlargement of the thyroid. The risk of cancer with a goiter is 3 to 5%. If you have symptoms with the goiter, like difficulty swallowing, sometimes difficulty breathing, a CT scan or an MRI can help us see if it's pushing on any of the structures in the back. If it's growing very quickly, very painful, or it's just really like rock hard, usually a biopsy is recommended just to make sure that it's not cancerous. Now going on to thyroid nodules. These are very common, especially in women over the age of 50. These are lumps in the thyroid. So as you see here, you have your normal thyroid, then you have some lumps here. This is just a goiter, and this is a goiter with multiple nodules. I get a lot of referrals for thyroid nodules because they're usually incidentally found when somebody gets a CT scan for another reason, and they're like, oh, they have several nodules. Generally, they're benign, and they're found in 6.4% of women and 1.5% of men. Unless they're very large, they're pushing on other structures in the neck, or they look cancerous on ultrasound, they generally don't cause trouble. There's some things that do increase the risk of nodules: smoking, obesity, alcohol consumption, high growth hormone levels, and uterine fibroids are known to be associated with thyroid nodule formation. Okay, so that's thyroid nodules. Now going on to vitamins in the thyroid, which is usually quite a popular question. So I mentioned iodine a lot. So iodine is really important for thyroid health. Iodine is needed to produce thyroid hormone. The body doesn't make iodine, so it's essential that it comes from the diet. It usually is found in iodized salt, dairy, seafood, eggs, multivitamins. It's released from the body via the urine. So the best way we usually measure it is through population urine samples, but we don't routinely test iodine levels. The recommended daily intakes in women are 150 micrograms here, a little bit higher in pregnant women and a little bit lower in children just because of body size. Pregnant breastfeeding women definitely need more iodine to provide it to more than one person. Now, what happens with low iodine? So if there's just a mild to moderate deficiency, the thyroid tries to work even harder to compensate for that low iodine. And so it starts to grow abnormal nodules. So low levels can cause nodules. And then if someone starts taking iodine all of a sudden, those nodules can turn hot and cause hyperthyroidism, which then kind of levels out and improves over time. Severe deficiency of iodine just leads to the thyroid really causing a goiter and just enlargement, and then an underactive thyroid gland because you don't have the necessary nutrients to make thyroid hormone. In terms of Graves' disease or thyroid cancer, it doesn't really appear to affect the risk of thyroid cancer, but there's some studies that show that correcting iodine deficiency may shift the thyroid cancer type from a more malignant form to a less malignant form. Okay, one thing I wanted to kind of really go over is the importance of iodine in pregnancy. So iodine in pregnancy is the leading preventable cause of intellectual disability throughout the world. With severe iodine deficiency in pregnancy, the developing baby does not produce enough thyroid hormone, and it causes permanent damage to the central nervous system. But also, chronic high levels of iodine should also be avoided because those can lead to hypothyroidism, and then the thyroid tries to work harder, so then the baby forms a goiter. Overall, iodine is very important in pregnancy because deficiency in the mother has been associated with miscarriages, stillbirth, preterm delivery, and congenital abnormalities and IQ changes in the baby. So the American Thyroid Association recommends that all women who are pregnant or planning to get pregnant take a prenatal vitamin containing at least 150 micrograms of iodine per day. And it's important to note that not all vitamins or even prenatal vitamins have iodine. It's really important to look at that bottle and make sure that there's about 150 of that. Not taking the iodine supplements alone, or not excess amounts, but definitely that minimal amount, especially in this case. Okay, second vitamin I want to go over is selenium. So selenium is found in meat, it's found in seafood, it's found in grains. Selenium deficiency is known to decrease the production of thyroid hormones as well. Some epidemiological studies have shown an increased risk of thyroiditis, Graves' disease, and goiter with low levels. But selenium has a very narrow therapeutic index, meaning with high levels or low levels, there can be problems, and there's quite a narrow optimal range. So I usually don't recommend selenium supplementation alone. The only time the American Thyroid Association has really only recommended selenium supplementation alone for Graves' eye disease. It's shown to lead to improved quality of life with those with eye involvement in Graves' disease, as I showed you earlier. And some trials have shown that it leads to faster remission of the hyperthyroidism as well. But as I mentioned, current recommendations are only to use selenium to those with Graves-related eye disease. So I just wanted to show you also kind of what selenium does here. So if you're deficient in selenium, it can increase your risk of thyroid autoimmune disease, decrease immune function, can possibly increase cognitive decline. But when there's too high levels, we see alopecia, dermatitis, it increases skin cancer risk, it can increase mortality overall, increases the risk of type 2 diabetes. So we usually recommend not to supplement, but just to increase intake through diet. It's really hard to go high on levels just through diet alone. So optimal levels decrease cancer risk, decrease diabetes risk, and overall are just good for the thyroid as well. And this U-shaped curve just means that there's a very narrow kind of range that's appropriate. Okay. All right, vitamin D. So vitamin D is known to promote a healthy immune system. The main sources of vitamin D are through sun exposure. Other dietary sources include milk, canned tuna fish, cod liver oil, yogurt, cereals. This is the one vitamin that it is okay to supplement with. So several studies in humans have shown low vitamin D levels to be associated with thyroid disease, but once again, the data on this is quite limited. So with Hashimoto's disease, there's some studies that show that taking vitamin D reduces those antibody levels, but once again, we don't check those antibody levels frequently anyway in Hashimoto's disease. So, other studies didn't really show any association. With Graves' disease, there's a higher incidence, some studies have shown a higher incidence of vitamin D deficiency in those who have Graves' disease compared to those who don't. Some studies suggest that an association between vitamin D and thyroid cancer, but then there's also a few conflicting studies. So to be honest, there's just not a lot of robust trials, but most studies do show an association between low vitamin D and increased incidence of autoimmune conditions, especially Hashimoto's. More studies are still needed, but vitamin D is reasonable to supplement with, especially if you live in cold areas or don't get a lot of sun exposure. Okay, so just vitamin D intake and optimal levels. So we usually go here in the United States by the nanogram per milliliter. So generally we want levels between greater than 20. We usually say greater than 30 to 50 are ideal. And that's generally considered adequate for bone and overall health in healthy individuals. These are the recommended amounts of thyroid hormone, depending on the age. And sometimes people take higher doses, and that's okay. But generally, you want a level between 20 and 50. Okay, and then often we're asked, is there a good diet for the thyroid? What should I eat if I have a thyroid condition? So as we know, iodine and selenium, adequate amounts, but not excess amounts are beneficial. And the best way to get an adequate amount of iodine and selenium in your diet is just to eat a healthy, balanced, varied diet. Cruciferous vegetables like kale, turnips, cauliflowers, also very healthy and have a lot of antioxidants, but there's evidence that very, very high amounts of cruciferous vegetables can actually decrease the production of thyroid hormones. So we usually recommend avoiding excessive amounts, especially it can really manifest if somebody's iodine deficient. But the normal amount of cruciferous vegetables in a normal diet is unlikely to cause any harm, and it does have the antioxidant benefits, so it's usually okay to continue. I do see a lot of questions. I will answer those at the end. As far as soy products sometimes have been shown to increase the formation of a goiter. They may inhibit thyroid hormones in those with iodine deficiency, so excess amounts are avoided, but small amounts throughout the diet are okay. So the conclusion is just a balanced diet is an important component of maintaining a healthy thyroid gland function, and just avoid excessive supplementation. Okay, and then another common question that we get is thyroid disease and hair loss. So generalized hair loss, there's different types of hair loss. So this type of hair loss is referred to as telogen effluvium. The hair loss has a resting phase and a growing phase. So when the hair enters the resting phase of the hair cycle, that's called the telogen phase, and that happens after the growing phase. The hairs are lost 3 months after it reaches that phase. So in TE, there can be up to 30 to 50% of the body hair can be lost. And things that kind of affect this phase are illness, injury, infections, crash diets, stress, giving birth, thyroid disorders, vitamin deficiencies, drugs. So thyroid disorders certainly can cause a diffuse type of hair loss. Both with hyper and hypothyroidism, though definitely with hyperthyroidism, one of the symptoms is excessive hair loss. Usually, though, hair loss is reversible when the thyroid levels are corrected, but it's important to remember these cycles can last a very long time. So I always tell my patients that it can take up to 6 months after your thyroid levels are normal to see any reduction in the amount of hair that you're losing. But the follicles are still present. It's not any type of scarring alopecia. So the chance of the hair coming back is still, the chance of the hair coming back once the thyroid levels are low and there's no other kind of stress incidents is always quite good. Okay. So complementary and alternative medicine in thyroid disease. So generally, this is referred to as CAM, generally not the standard of care. The standard of care is based on scientific evidence, but the National Institutes of Health and the National Cancer Center say, of course, it's definitely fine to use CAM with standard medical treatments. So some of these CAM type of treatments include mind-body exercises such as yoga, meditation, hypnosis, all which we know kind of increase that parasympathetic nervous system, can reduce cortisol levels, so are always good to try. Other things include vitamins, herbs, and special diets. I mentioned the vitamins earlier. Just healthy, varied diet is the best way to get the vitamins rather than taking excessive supplementation. Okay, so I just wanted to go over some studies here just because there's not a lot of evidence on CAM and different types of diets to go with the thyroid. So what about gluten-free diets? So as we know, there is an association with celiac disease and other autoimmune disorders. This study in particular looked at about 100 patients with celiac disease. Sorry, they looked at the prevalence of celiac disease in 100 patients with autoimmune thyroid disease, and about 2% of those people had celiac disease. They tried a gluten-free diet, so asked 2 of these patients to try a gluten-free diet, but only 1 actually accepted, so this is just based on 1 person. But the patient who took the gluten-free diet showed complete remission of the Crohn's disease in 6 months. And then all 3 of the blood markers that we checked for celiac had disappeared. But for some reason, there was an increase in the thyroid antibody titer. So in this case, it really didn't work. And it's difficult to make a proper choice for undertaking a gluten-free diet based on just kind of lack of studies that we have here. It's also really difficult to do these types of studies because there can be so many confounding variables. And we also know that antibody titers aren't necessarily the best to measure in Hashimoto's disease. So we have another study here that's a little bit more robust. So in this study, we wanted to investigate whether gluten-free diets affected thyroid autoimmunity and those with Hashimoto's disease and positive anti-tissue transglutaminase antibodies, which are high in celiac disease. So 34 women with autoimmune thyroid disease were divided into roughly 2 equal groups. The first group got a gluten-free diet for 6 months, and the remaining patients just used their usual diet. And they found that the antibody titers actually went down in the gluten-free group. So this study concluded that a gluten-free diet may actually bring clinical benefits to women with autoimmune disease of the thyroid. Once again, it's not something that I recommend routinely just because we don't have robust evidence on it. Could it work? Sure. So a trial is always reasonable as long as you're getting the micro and macronutrients from other sources. Then another study that we have here is yoga, the impact of yoga upon female patients suffering from hypothyroidism. Once again, very difficult to see if these types of studies actually lead to any clinical changes. So in this study, 20 patients who were hypothyroid attended 1-hour yoga sessions daily for 1 month. And before they started the yoga sessions and after they started the yoga sessions, just a quality of life scale study was completed. And the conclusion overall was just that they really reported significant improvement in their perception of overall quality of life and health after the yoga intervention. Now, did it affect the thyroid? I'm not sure, but overall, it can definitely be considered as a supportive or complementary therapy in conjunction in medical therapy. Definitely can be beneficial. So no reason not to try. Okay, and then going back to a little bit more thyroid, going back to the radioactive iodine I mentioned. So I'm just kind of wrapping up here, but just wanted to touch base on some of the other questions that we get with the thyroid briefly. So radioactive iodine is also called iodine 131. It's used for the treatment of hyperthyroidism and for thyroid cancer. The dose that we use for hyperthyroidism is much, much smaller than the dose that we use for thyroid cancer. So what radioactive iodine does is it destroys thyroid tissue and it leads to low thyroid levels. Very, very high doses, greater than 400 MCI, have been associated with increasing the rates of cancer. But for low doses, such as those used in hyperthyroidism, they usually result in none to, if any, cancer risk. Although there was just one study that came out recently that showed a slight increase in breast cancer risk and solid organ cancer risk after treatment with very low dose iodine 131 for Graves' disease. So this newest study was a little bit conflicting, but in general, the low doses do not have adverse effects. Okay. Okay, going on to thyroid cancer risk. So thyroid cancer, the incidence of thyroid cancer is going up, and it may just be because we're getting better at detection of thyroid cancer. So what increases the risk of thyroid cancer? This is adapted from the American Cancer Society. So head or neck radiation treatments in childhood increase the risk of thyroid cancer as they do any other cancer. Before the 1960s, children were also sometimes treated with low doses of radiation for acne, fungus infections, enlarged tonsils, or adenoids, and years later, they were found to have a higher risk for thyroid cancer. X-rays and CT scans, X-rays much less than CT scans, also expose children, but at much lower doses. And with adults, CT scans, it's more the repeated exposure. With adults, the risk is less. Being overweight or obese has been shown to be associated with a lot of different types of cancer, so also thyroid cancer. Follicular thyroid cancers are the more benign types of thyroid, not benign, but follicular thyroid cancers are the less aggressive types of thyroid cancers, and they're often seen in areas of the world where people have low iodine in their diets. But on the other hand, it's shown that a diet very high in iodine may increase the risk of papillary thyroid cancer. Both follicular and papillary are the less aggressive types of thyroid cancer. Once again, it just shows like really keeping that iodine level normal and not high and not too low. Family history of thyroid cancer increases one's risk, and then certain hereditary conditions listed here, which are a little bit more rare, those increase the risk of thyroid cancer. The good thing is that 90% of people survive thyroid cancer, and it's generally treated with removal of the thyroid gland and then radioactive iodine, which is different from just general radiation with cancer treatments. So it is very treatable. Okay, and then just a word on nuclear power plants on the thyroid, and just to give a bit of a historical perspective as well. So one of the most abundant substances in that can come out of a cloud of a radioactive stream from a failing nuclear plant is iodine 131, the same treatment we use to treat hyperthyroidism and thyroid cancer. And this can be breathed in, it can be taken in with food after the particles settle onto soil and water, and then we use that soil to make food, or from milk from exposed animals who take in the iodine 131. So as a historical perspective, following the explosion of the nuclear reactor in Chernobyl in 1986, there was a significant increase in thyroid cancer in Belarus and the USSR, and it was linked to the iodine 131 exposure. Illinois has 6 nuclear power stations, and most studies luckily show no increased risk of thyroid cancer just by living near a nuclear power plant. There's really no concern. Nuclear radiation in the thyroid. So just to give a little bit more perspective, so the thyroid is really the only gland in the body that absorbs all the iodine. So the thyroid usually absorbs any available iodine that you take in through the diet into the bloodstream to make thyroid hormones. It can't really tell the difference between regular iodine and radioactive iodine. So if there is a small nuclear accident, there is release of radioactive iodine into the atmosphere. And if the cells absorb too much of that radioactive iodine, it can cause thyroid cancer to develop years later. Thyroid cancer is the only cancer, though, whose incidence seems to rise after radioactive iodine release and not other types of cancer. So potassium iodide pills are sometimes given, and I'll go over that in the next slide, to protect the thyroid, because it's really only the thyroid that's the greatest risk from the radioactive iodine. And not just thyroid cancer, it can cause thyroid nodules, just hypothyroidism, hyperthyroidism, so many things. Oh, just one more slide. So just lastly, so the Department of Health and Human Services recommend that people who live within these nuclear power plants, and there's about 6 of them in Illinois, keep potassium iodide tablets at home. Beyond 50 miles, the exposure would be less likely from the atmosphere and more due to ingestion of foods or contaminated particles, but it's really hard to predict how far these would spread. The priority is always evacuation, sheltering, avoiding contaminated foods and beverages. Once again, the risk of this is very low, but it is a disclaimer for the general public, for anyone who lives near one. And that concludes my talk. Oh.
Thank you, Dr. Kurani. That was wonderful. We have a few questions from the audience. So let's go ahead and get started. The first one is, how much should the T3, T4, and TSH levels be for a person having papillary carcinoma and taking Synthroid so the hormones stay suppressed?
Yeah, so that really depends on how far somebody is out from the papillary thyroid cancer. Within the first year, we like to keep the TSH quite low. So we like to keep the TSH like less than 1 actually, because TSH is thyroid stimulating hormone. So higher levels of TSH can stimulate any remaining tissue to grow back. So especially after the first year, we recommend keeping it. Usually we recommend, depending on how aggressive the cancer was, sometimes even closer to 0.1. But usually it's between 0.1 to 0.5 right after cancer treatment. And then after a year or two, if there's been no recurrence, it changes usually to around 1. But usually even after long-term, any kind of thyroid cancer, papillary thyroid cancers, we keep it quite low. So after a year or two, it's usually closer to 0.5 to 1. Mm-hmm.
Thank you. Yes, so you do keep a little lower compared to other conditions. Mm-hmm. The next question, can selenium levels be tested? How does one know how much selenium is there in the body?
We can test selenium levels. It's something that we don't frequently do, but certainly they can be tested. Yeah.
Okay. You got a compliment saying there's a lot of practical information there. The next question, did Dr. Kurani say thyroid hormone amounts for the right side of the previous slide regarding vitamin D? I think it's a question about vitamin D and thyroid hormones.
So as far as vitamin D, the optimal level in the United States normal is considered usually above 30. So anywhere from 30 to 50, usually we like to keep it closer to 40 or 50, the vitamin D3, 25 OH vitamin D. Mm-hmm. And then usually the recommended amount is around 800 to 1,000 international units per day of vitamin D3.
Thank you. Mm-hmm. All right, the next question. Does it matter how much of iodine and cruciferous vegetables I eat if I'm already on levothyroxine?
Yeah, so that's a good question. It's probably not as much because you're already receiving, you're already getting what you need through the levothyroxine. So unless there's, it really should not matter. But we still recommend avoiding excessive amounts. The cruciferous vegetables, for whatever reason, are still shown to increase the risk of a goiter. And I don't know for sure if that's independent or not from just iodine content. So we would still say avoid excessive amounts. But generally, it does not matter because you're already on supplement. Mm-hmm.
Just the normal diet. I mean, don't take too much of it, but you don't need to avoid it either.
Oh, no need to avoid. They're actually healthy. I never say to avoid. Just extremely excessive amounts. Mm-hmm.
Okay. Next question. On the flip side, if a person is hyper, would eating a lot of cruciferous vegetables help correct this condition?
I'm not sure I know the answer to that, to be fair. I'm not sure.
Okay. Next question. Can a thyroid disease cause a tickle in the throat feeling?
So certainly thyroid disease can lead to inflammation of the thyroid gland, which any enlargement of the thyroid gland can cause this, what we call difficulty swallowing. It can feel like some people feel like they have a globus sensation or something stuck in the throat. As far as a tickling feeling, that's usually more related to postnasal drip. So it potentially could be exacerbated by the thyroid, but it's likely not the primary cause of the tickling feeling.
Okay.
Mm-hmm.
Sounds good.
Okay, so moving on to the questions from the Q&A box. Let's see here. So do thyroid nodules continue to grow bigger? Can you please discuss the use of radio frequency ablation, which is used in some states, but not Illinois, to reduce or eliminate the large nodules?
Nodules that are not cancerous usually do not grow that rapidly. If there's a nodule that's rapidly growing, that concerns us for thyroid cancer. The only ones that tend to grow a little bit quicker are the nodules that are cysts or have fluids in them. Those can reaccumulate. Radiofrequency ablation is not something I've ever used. There's some studies, and there are definitely physicians who use radiofrequency ablation for goiters and thyroid nodules, but it's not something that we do routinely in clinical practice. There's no real other way to shrink goiters or nodules apart from surgery. Some doctors prescribe levothyroxine, to reduce the amount of stimulation on the thyroid gland to prevent the nodules from growing, but that's not routinely recommended.
Okay. And I mean, even for cosmetic purposes, you don't recommend.
I just don't have enough clinical practice with radiofrequency ablation, and it's not standard practice. Mm-hmm.
Okay.
But there's a lot of growing evidence, and there's a lot of physicians that do use radiofrequency ablation, mm-hmm. or some physicians. Mm-hmm.
Okay. And moving to the next question, I've seen patients with hypertension with hypothyroidism. Any comments on that?
Yeah, so hyperthyroidism is a state of just thyroid hormone excess, and it can lead to hypertension. So both hypothyroidism and hyperthyroidism lead to hypertension. With the hyperthyroidism, usually there's tachycardia or a fast heart rate and hypertension. So one of the treatments that we give for hyperthyroidism that's not controlled is a medication to slow down the heart rate and to bring down the blood pressure until the thyroid medication kicks in. So absolutely, uncontrolled hypo or hyperthyroidism are associated with hypertension. Mm-hmm.
Yes, and it is actually, they're the causes of secondary hypertension. That's what we call them as. Okay, moving on to the next question. Use of cryoablation for thyroid cancer. Any comments on that?
Not routinely used. Once again, the standard of treatment for thyroid cancer, depending on the type of thyroid cancer, is removal of portion of the thyroid gland or the entire thyroid gland. Not everyone needs radioactive iodine, but some people also need radioactive iodine after the thyroid is removed. Cryoablation is just not standard of care.
Okay.
Mm-hmm.
And then this is the last question in the Q&A box. Is there any benefit to overcorrection of hypothyroidism by increasing the dose of L-thyroxine in the face of high normal TSH on treatment?
So as long as somebody does not have thyroid cancer, we usually just treat the TSH to goal. In people who are younger, we try to keep the TSH below 2.5. So for example, if it's a younger woman of childbearing age, we want to keep the TSH below 2.5. But if you're not in that group, we just want to keep it below 4. Some people feel better. Some doctors like to keep the TSH closer to 1 because they feel that people feel best on that. Once again, TSH has a wide range. So if someone's at 3 and they don't feel well, even though that's normal, you can try going up on the dose to bring it down to 1 to see if they feel better. There's a range for the thyroid hormone.
Sounds good.
Mm-hmm.
Dr. Bhupalam, do you want to take the